Good afternoon. I want to welcome everybody to the 4 o'clock session of the UCSF Family Medicine Rodnick Colloquium. I'm so glad to see everybody here. Just so you know, the session is being recorded. This is a very special session of the Colloquium. This is the time when we really get to hear about the amazing work that's being done in diversity, equity, inclusion, and health advocacy in our community. We have incredible panelists and discussion leaders lined up for ourselves today. Every year we ask ourselves, what can we highlight? And the answer is like everything. We like everything. We're family medicine. So this is what we call the headlines panels. Think of this as movie trailers. What it is that each group is going to give you just a 3-minute highlight of the work that they're doing. And at the end of that time, we're going to all log out of this webinar and then ask you to pick a Zoom link for a session to go to where you can actually have more chance to talk, to share experiences, to meet collaborators. So you'll be logging out of this. The Zoom links are in your email. They'll also be in the chat. I want to just go ahead and show you what the, show you what the sessions will look like, just so you can start thinking ahead about what you might want to participate in. Unfortunately, it's right in the wrong spot. So let's see. So this will be for the afternoon. This is the order of the sessions that we're going to have, the exciting topics, and there's a lot to think about here. So we'll hear from all presenters on all of these areas, and then you can pick the session at the end that you most want to go to. Although we would encourage you to reach out to everybody on this group for over the upcoming year to talk more and to think about these issues. And before we go any further, and I just also want to say one more time, thank you to all of our incredible presenters today, volunteers, participants, our amazing staff, Dion Johnson, Roy Johnston, Jill Thomas, Amber Kobit have been just amazing in keeping us through this, and especially thanks to you for joining us today. So I'm going to let our panelists introduce themselves. The first group that we're going to hear from is Dismantling Race-Based Algorithms, Guidelines, and Calculators. And I will, hopefully, turn it over to Monica for that. Thanks.
Great. Thank you so much, all. Can you see my screen okay? Hopefully that's all good. So hi, everyone. I'm really grateful to be here today. I'm Monica Hahn. I'm faculty at our UCSF program, and for this panel, I'm joined by my colleagues, Dr. Juliana Morris, and student Dr. Shrey Goel and Maddie Kane. In our small group, we'll be discussing the topic of challenging notions of race-based medicine while highlighting a specific example of advocacy to abolish race-based EGFR. So just to briefly introduce the topics, I only have 3 minutes. I'll take a quick moment to talk about some of the historical context, why flawed race-based medicine ideology is problematic and can lead to worsening health inequities. So first off, let's be clear, race is a social construct, no biological basis. People may share some phenotypic characteristics like skin color and hair color, but that actually says nothing about how similar they are genetically. This was actually confirmed with completion of the Human Genome Project over 2 decades ago. So what we do know is that racial categories are arbitrary and have changed over time. They were initially made up long ago in the 17th century, have evolved Eurocentric ideas to justify colonization, genocide, and slavery, and were further codified into medicine by early scientists and doctors like Samuel Morton and Carl Linnaeus with the intent of proving racial superiority of white colonizers. So in short, racism came first, and the man-made invention of race created from it in order to justify white supremacy ideology. And unfortunately, this legacy continues today in medical diagnostic tools with built-in racial correction factors that we still use every day, like the spirometer, like EGFR. And these ideas unfortunately laid the groundwork for many other unjust practices on minoritized communities, such as the US Public Health Tuskegee syphilis study, forced sterilization, and countless other examples. So there are many other examples of race-based medicine and clinical tools and calculators that we don't have time to go over, but I'll say that there's these resources here that I'd love for people to check out when they have time. These are all examples of structural racism in medicine and how mechanisms of inequity are woven into the very medicine we practice. Some great articles and reports are here, and these include EGFR, VBAC calculator, spirometry, think you all are familiar with these. So I'm real quick to end. Proud to say that after a powerful advocacy and petition effort, we were successful in abolishing race-based EGFR here at SF General in 2019, followed by all of UCSF in 2020, and many other institutions have followed suit. And much of this national advocacy and organizing has been housed within the Institute for Healing and Justice in Medicine, which we co-founded in 2020, where we're leading several national working groups to abolish race-based medicine in several areas. So I had the honor of being invited by AAFP to present to the Family Medicine Leadership Consortium on this topic a few months ago, and just thrilled to continue this discussion here and at a national level. So I'll just end by saying this is hopefully a small step in the right direction for further advancing the much needed discussion of interrogating and dismantling all forms of structural racism that are so deeply rooted in our healthcare system, with hopefully family medicine activists continuing to lead the way. So thank you. I hope you'll join us for exciting more discussion beyond 3 minutes and other ways to get involved. Thank you.
Thank you, Monica. That was an amazingly powerful 3-minute discussion. You set the high bar for us all, as always. I want to go ahead next and introduce our next group, which is Building Agency Through Racial Affinity Groups and Caucusing. Thanks.
Hello, welcome. I think we have a slide. Do you have my slide? I don't see it, so I'm going to go ahead and present. I'm Linda Russell. I'm a care coordinator and an MFT part of the behavioral health team here at John Muir in Walnut Creek. And what affinity groups are groups of people who share a common experience. And in this particular discussion, we're going to focus on race-based affinity groups and the unique opportunity they present for open sharing in discussion. And we're we hope that you will join us. There are 3 of us who will be facilitating the discussion at 4:30. And so we'll hope you join us to get some additional information on how to utilize these groups to really broaden and allow for open conversation.
Thank you. That was also an incredible encapsulation of a huge topic into 3 minutes. The next topic that we're going to hear about is family medicine as in our role as anti-racist advocates, empowering ourselves as effective change agents through community organizing efforts and our aim at dismantling racist structures. Thanks. It's looking like, nope. It's looking like that group may not be ready just yet. So I'm going to move us ahead if that's okay. We'll come back to that group. If it's okay, if the next group is prepared to go, I hate to put you on the spot, but I'm going to go on to the next group, which is DEIA. It's meant to be tough work, dialogue around missteps, missed opportunities, and structural barriers to advancing DEIA. Thanks.
Wonderful. Thank you so much, Margot. I am Tessa Steckerman, with the faculty members at the KP Napa Solano Family Medicine Residency Program, and it's my honor and pleasure to present on behalf of our entire residency program, who has been committed to doing this work for the last several years. And really what we're going to do in our breakout session is think about the ways in which diversity, equity, inclusion, and anti-racism and anti-oppression principles can be applied to clinical care and medical education. And particularly thinking about some of the ways that this can be challenging and overwhelming work to pursue, and some of the lessons that we've learned in doing this work in our residency program. In thinking about this work, one of the reasons why it's challenging and overwhelming is that there are so many things to consider, not only in terms of thinking about sort of individual level factors of implicit bias or unconscious bias and how that contributes to our communication with our colleagues, with our patients, how that contributes to our decision making, but also thinking about the systemic, structural, policy level forces that contribute to this work and the historical legacy of systemic oppression and racism in this country. Not only that, but where do you begin, right? Do you consider evaluation and feedback? Do you consider recruitment? Do you consider the way that you create your curriculum or the ways that you design your lectures and presentations? And so it can be a very overwhelming process. I've been fortunate enough to work with a wonderful group, and we have learned some lessons in doing this work in the last few years. This is just a smattering of some of the examples of the lessons that we have taken away in doing this work. One of the things is really in prioritizing this work. This is going to require time, resources, and energy. Sometimes your residency program, your medical institution, your department is not ready because you have other priorities. You may be new and you have to focus on just doing some foundational elements, or you have some challenges or other things that have come up. You really want to make sure that you have the buy-in from all of the potential people who need to be involved, and that there is time and space created for this. Like I mentioned before, you can't do it all at once. So thinking about where it is that you're going to start and focusing on that and building on that, and then hopefully that will have a lasting impact. For us, we really focused first on, as I mentioned, implicit bias, unconscious bias, but also focusing on recruitment efforts, creating safe spaces for our resident physicians, and then incorporating some other principles in terms of faculty development. Creating a needs assessment is very important. Thinking about not only what are the needs specifically of your community, of your institution, of your medical institution, but what are the resources that are available at your disposal. We're lucky enough now that there's a DEIA work group within the Colloquium that has a wonderful list of resources and great people who are doing this work day in and day out that you can tap into. Considering all of the stakeholders, who needs to be involved in making these decisions? Do you have buy-in from the program leadership? Have you considered the impact on your support staff, on the MAs? Are you focusing on just one area or the other? And then developing an evaluation strategy. So this is an area that we discovered that we could have done this a little bit earlier in terms of thinking about the evaluation strategy, particularly because a lot of this work is new. For many of us, this wasn't incorporated in our own medical education. And by evaluating the work that we're doing, we can better share best practices with other people who are also doing this work. And then lastly, thinking about the synergy between your own educational program, but also the larger department or the institution. Are these priorities aligned? Your resident physicians, your medical students are not just going to exist within your residency program or your medical school, but they're going to go out. They're going to be part of every department. They're going to be interacting with other specialties, with other stakeholders. And so thinking about how can you reinforce these principles and lessons along the way. Thank you so much for this time. We hope to see some of you at our breakout session.
Thank you for a very, very insightful and powerful overview with beautiful slides too. The next group that I want to introduce is Taking Action for Trans and Gender Expansive Care. Thank you.
Hi, everyone. My name is Emiliano Lamos. I am a UCSF MS4 and glad to be speaking about this topic today, hopefully in small group with some of y'all also. I'm here also with Lena Kaur, who's a colleague and friend of mine, and Alexis Hoffkling, who is a resident at Kaiser Santa Rosa, finishing up there, will be joining us for the discussion group. Do you want to go to the next slide, Lena? Thank you. So our question in general is how, as family medicine practitioners or family medicine world workers, can we mobilize and support transgender and gender expansive communities? One of the first pieces that we want to highlight is that there's been a lot of policy stuff happening this past year and a number of years past. California in particular is a bubble, and the Bay Area even more so, as we know, where trans folks have substantial non-discrimination protections, and also gender affirming care is required to be covered by insurance. We actually see the pattern that people move to California for trans healthcare. And this is far from the case elsewhere. Many people might have heard about in March, Arkansas passing a bill to ban gender affirming care for trans youth. And many other states have been vowing to take the lead, with also banning trans youth from sports or banning trans youth from using bathrooms that align with their gender identities. There's been a lot of this up this year. And in addition, when these types of threats occur, they take a significant toll on the well-being of trans people, not just in the location where those things are happening, but across the continent. One example is that Trans Lifeline, which is a helpline for trans folks across the nation, a great organization. They experienced a 400% increase in calls when Trump announced that he was trying to legally define gender as solely male or female in a binary way based on sex assigned at birth and unchangeable. But in a bigger way, just zooming out, this is also a time of change. We have this quote here from Biden that he delivered in his address to Congress in late April this year. To all trans Americans watching at home, especially the young people, you're so brave. I want you to know your president has your back. And that's remarkable to come from the mouth of an American president, right? And at the same time, like, Joe, don't tell trans people they're brave. It's a little tacky. So our overall question here is, as family providers, what can we do to advocate for coverage and protection for trans folks across the US? I'm going to pass on to Lena for a couple other points.
Yeah, thanks, Emiliano. So as I'm sure many of us have seen in our practices, gender affirming care is increasingly moving towards primary care and family medicine, I think, as they should be. And while we live in California, which is a state which has a lot more protections than some others, we still are not as at the place where we should be. According to the US Transgender Survey in California in 2016, 33% of respondents who saw a healthcare provider reported having at least one negative experience related to being transgender. And 22% of respondents didn't see a doctor when they needed to because of fear of being mistreated as a transgender person. So, you know, if 1 in 3 people are having this experience at least once, and 1 in 5 people are not even coming to the clinic at all, I think that we have a large space to grow and step it up. And one of the biggest decrees by the transgender community is that they'll no longer be accepting misnaming or mispronouncing. However, and I imagine many of you as well, have had several experiences hearing staff misgender patients. As a trans patient, staff member, and provider, it can be incredibly exhausting to constantly feel the need to advocate for patients and educate staff. So something that we also want to talk about is how can we make structural changes to meet these calls so that it doesn't rely on just an individual. As the presenter before us said, how can we make sure that on an institutional or clinic level, we're actually creating sustainable change?
So join us if you'd like in a little bit. Thank you.
Thank you for a wonderful presentation. And may I just point out, those are our students. I'm so excited. And residents, excuse me, resident too. The next topic we're going to hear about is pursuing health equity, vaccine equity in action through collaboration in Contra Costa County. Thanks.
Hi, everyone. Thank you for being here. I'm going to run through the slides very quickly. And I'm here with a group of partners, but we are going to do this very, very quickly. My apologies. Okay. So this is a story of a partnership between local government and a nonprofit community hospital working together to achieve health equity, and of a mobile clinic, just one that has been around for 2 decades. We've been through emergencies before, helping through fires and smoke, and we learned, working through blackouts, and we learned, but no one was ready for this. Despite decades of work on social determinants, what happened? A global pandemic, which hit our most vulnerable communities. This was the same in San Francisco and across the county. And though our county and our health system begin with vaccinating nursing homes and healthcare workers, we soon discovered that when you open up access equally, vaccines were being given to people who lived in the most affluent areas, because equal access does not translate to equity when the system itself is structured inequitably. So we got to work starting with analytics. And by the way, you can do this if you have Epic or other electronic medical records, and we can review it with you if you want. Demonstrating with data what we were all concerned about, and we did not wait for the third-party organization from the state. We went to business meetings, vaccine meetings, and constantly met with our county partners behind the scenes. We made a business plan appealing to different work styles, and we'll share this strategy in our breakout session. And we rallied both systems to cooperate, bridging private, public, leveraging size and influence while keeping governance nimble. And from our experience during other emergencies, we knew that physicians are only part of the critical team. And this is what we will share too. And made a business plan, which we pushed in both systems, John Muir Health and Contra Costa County. We will share how to leverage the Healthy Places Index, HPI, to target your locations, and people will come to help because we are in healthcare, and more people will come and help. And we'll share how to outreach to the overlooked and those who don't speak English and are not usually addressed by the health system, and how your rates for BIPOC access can exceed state and regional rates and make real impact in the communities. As we know, equity needs more than just talk and about hesitancy. It takes outreach and time, it takes work, and it takes a team. And as we know, equity needs more than talk. It takes work and a team. What will we do again? What didn't work? How can we do more? Please join Isis and Dr. Nath for our session, and my colleagues as well, Sarah, Gilbert, and myself for the Addressing Equity Needs Through Outreach and Partnerships. Thank you so much.
Thank you for that wonderful presentation. It's exciting. The next group we're going to hear from is amidst a challenge to Roe versus Wade, what is the role for family medicine? Thanks.
Hi, so I'm sure many of you saw the same terrifying news alert that I did, announcing that the Supreme Court will be hearing the Mississippi 15-week abortion ban case, which is seen as a direct challenge to Roe v. Wade. In this case, the Supreme Court will be focusing on if states can ban abortion before fetal viability. Currently, 22 states have laws on the books to restrict or ban abortion if Roe versus Wade is overturned. Also, just last week, Governor Abbott in Texas signed a bill that bans abortion as early as 6 weeks. That bill is designed to sidestep legal challenges by allowing anyone to file a civil lawsuit against abortion providers and people who help others get abortion, with penalties starting at $10,000. So what can we do? Family physicians who provide abortion care increase abortion access and reduce the burden on abortion clinics. Our team has been conducting a study to develop communication strategies to motivate and support family physicians to provide medication abortion in primary care. And as part of that study, we've developed audio stories. I'm going to leave you with one of the patient audio stories that demonstrates some of the challenges people currently face to getting abortion care in the US. And I encourage you to join us at the breakout session if you want to brainstorm ways that we as the family medicine community can work to protect and expand abortion access.
My name is Malihos. I am 26, almost 27 years old. I was 20 years old when I got pregnant. Literally felt like my world was collapsing because that is not something I wanted or expected, and that was not something I was in the financial situation to handle. So I knew that I wanted to have an abortion, but what I didn't know was how hard the process was going to be in the United States, because I'd also only moved to the US a year ago. I came from Pakistan, and while we're definitely not the most liberal country on the planet, but abortion isn't as big of a deal as it is for some people here in the US. So I tried Louisiana. They told me that I can only be living in a certain mile radius, and because I'm not, they're not going to do it. And again, I was like, okay, where else can I go? And then I found Colorado. So I ended up going to Colorado Springs. And when I realized how easy the process was, I was so angry. I was like, I can't believe I literally got on a plane pregnant, flew to another state just for a doctor to hand me 2 pills. That's all. I literally went through all of this, paid all of this extra money for a doctor to put these 2 pills in my hand. In an ideal scenario, well, the insurance would be able to cover it. I would be able to discuss it with a doctor that I know, I like, and trust. And it would have been convenient for them to just, mail in a quick prescription, me go pick it up, and me take care of it at home. And then whether or not, if I just want to go for a follow-up, make sure I'm all good. So I think that would have been wonderful.
Wow. Thank you for that very powerful audio clip. That was really very provocative. I would encourage everybody to join that group if they want to go talk about challenges to Roe v. Wade. The next topic that we have, it's hard to transition after that powerful segment, but is health policy updates, the Biden administration since the Lancet report. And then after that, we will circle back to FCM's role as anti-racist advocates. So first, Kevin, thanks.
Hello again, everybody. All right, I am going to sort of help facilitate a discussion about sort of policy issues of interest. So the first one I will address is an update to grand rounds I gave a few months ago about the Lancet Commission on Public Policy and Health in the Trump era, on which I was privileged to participate. And that report described the four years of really execrable actions that set back health in the United States as well as globally, but in the context of 40 years of failed policy in the United States to invest in the conditions conducive to equitable and good health for all in the United States, again in the broader context of 4 centuries of oppression and genocide. So now we're in the Biden era. So what's to come? So we'll talk about how the Biden administration has reversed the worst of Trump administration health harming actions. Emiliano mentioned his statement on transgender folks, and it may not have been the most elegant way of phrasing it in the classic Biden mannerism, but still the intention was quite good. So we'll talk about progress that's been made already on things like climate change, re-entering the Paris Climate Accord, some actions the federal government has been able to take on reproductive health, certainly the management of the pandemic, and a variety of very positive trends, and bolder than expected in several areas. The first president to mention white supremacy in a speech, as he did on his inaugural address. But at the same time, some limited change in direction on foreign policy, as a recent Middle East conflagration has made clear. The failure to really challenge the market-driven approach to healthcare and move towards healthcare for all in a much more publicly accountable manner. We'll then get to an issue that both Emiliana and Sarah addressed, which is states and how much of the action now in policy, particularly affecting health, but more broadly, is happening at the state level. And this is a term that's actually drawn from an article by my son, who's a political scientist, but states as a laboratories of democratic backsliding. They used to be called the laboratories of democracy, but we're seeing, all this rolling back of voting rights, of reproductive health, and so forth are happening now at the state level and what the implications of that are. And then the third thing, kind of depends on what people want to talk about, but there was a report that was issued this month by the National Academy of Medicine, their first report on primary care in 25 years, that talked about some strong implementation measures like establishing a Secretary's Council on Primary Care. So if people are interested, we'll talk more about that report and how to move forward some of those implementation plans. Thanks. Oh, and actually, before I realize, since I do have the floor, but I do, because this is the last time we'll all be here collectively. I know we'll turn it over to Roberto and Nathan in a minute, but I do want to give thanks again to Margot, to the entire team that organized another incredible colloquium. To me, inspiring, fabulous presentations and workshops that I went to. You can't all in the audience communicate by chat. You can't use your, applause icon. What I would ask all the participants to do, though, is to go into Q&A and just use the Q&A to please give a shout out, a thanks, give your props to the incredible team that worked so hard to pull off another successful colloquium, because they've just done a fabulous job. So please offer some comments in the Q&A as we're moving to this last session and heading out to breakout. All right, back to you, Mara.
Thanks, Kevin. That was really sweet. And I want to just add my incredible thanks to all of the team members who worked on this and all of the participants, all the panelists. And now it is my great pleasure to welcome Nathan and Roberto to talk to us about family medicine's role as anti-racist advocates.
One moment.
So I'm hoping that Roy can play slides or someone can play slides.
I'm still opening the slides.
Oh, thank you. So good afternoon, folks. Roberto Montes. I work with the Center for Community Engagement, Engagement Health Policy Program at CTSI. And I've been with the department.
Roberto, a little hard to hear you, Roberto. I don't know if you can lean into the mic a little bit more. Thanks.
Okay, sorry. Can you hear me better now? If I speak up?
Yeah, that's better. Thank you.
Okay, so I began with family medicine about 20 years ago as a community partner and a community advisor on a project to build community university partnerships. And I've been with the department now about 16 years, helping to build those kinds of partnerships. So today I'm going to just share a glimpse of some of that work. I was asked to talk a little bit about experience with organizing and advocacy. So if I look at the trajectory for the institution and think about the perspectives I've heard, about a decade or so ago, I remember explicitly, one of our faculty saying, our job is to provide the science so that others can advocate, right? And then the landscape for our country, certainly, and for science generally shifted dramatically, after an election around 2016. And I remember hearing distinctly faculty saying in a public forum, it's our duty to advocate in defense of science, right? And I was like, wow, that's beautiful. That's a shift in perspective. And then more recently, in the last year, I've heard folks say things like, we have a historic opportunity to decolonize research in medicine. So from my perspective, the prevailing opinion is shifting over time and in a direction that I like personally. Next slide, please. So the work that I do actually with Kevin and other faculty and staff colleagues of ours is it includes building community partnership, building the capacity of folks internally and externally to engage in those kinds of partnerships. And because of the translational science mission of CTSI, includes things such as translating evidence to policy, which is where I think there have been some opportunities around advocacy and organizing. For some of it, we played the role as an institution of providing the science, leveraging our research and discovery for others to really advance by way of organizing and advocacy. And that has included doing things like advocating around how San Francisco policy around retail sale of alcohol and colleague like Laura Schmidt, that similarly around policy change about sugar drinks, among other things, and then very recently, just right before the pandemic, Dr. Grumbach, other leaders from across the institution, and myself, very much as a result of the efforts of Paula Fleischer and others, helped bring leaders to Alabama to more deeply explore our country's history with race and racism, and the efforts of folks in the freedom movement to make change and to advocate and advance the freedom of all. This is a glimpse of that. And of course, things shifted with the pandemic. Next slide, please. During the pandemic, we saw folks at the community level organizing and advocating for response around how the city and other governments and entities address the needs of folks during the pandemic. And this is one example that I hope we learn more about in the panel discussion. The Do No Harm Coalition activating a DEIA in front of Mayor Breed's home, just one example of many activities. And in this case, an activity advancing the priority for housing houseless folks in San Francisco in order to protect them from exposure to COVID. Next slide, please. We have a number of different slides here to just scroll through that show examples of where folks in the Mission District, maybe Hunters Point, and elsewhere have organized to provide food distribution, supportive social services, testing, and now vaccinations. And much of that work has included partnership with folks from UCSF. For some of these examples, we've provided the PPE that we're distributing that you can see in those boxes. We have folks like Dr. Jonathan Butler mobilizing food distribution for seniors citywide. We're talking nearly 100,000 meals delivered. And then, of course, there's the activism on the streets. And here we've got this example of folks from Do No Harm and others providing medical support out at the protests, very important protests against injustice and for advancing racial equity that happened in this past year. So lots of great examples. Look forward to seeing you all at the next panel so we can learn more from our esteemed colleagues who are really doing this powerful work on the front lines. And thank you all for your time.
Thank you, Roberto. Those are beautiful images and great words to end on. We appreciate your surmounting the technical challenges to be here and join us with this. This has been a wonderful experience, a wonderful day of being together. I really want to express my appreciation one more time and would urge you to all join your breakout group of choice so that we can talk more and hopefully begin some collaborations that will last year round. Thank you.